Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm talking with Mark on nutrition and critically ill patients. How you doing, Mark?
I'm doing well, Dennis. Thank you for inviting me back.
I appreciate it. Now, obviously, we usually have you on for surgical type topics, but I think another really important part of that is beyond the resuscitation, beyond the wound care, the antibiotics, et cetera, et cetera. At some point, we may have to feed this patient, and sometimes our patients, they don't get evacuated. Nobody is going to come get them. And I'd like to start talking about what do we do beyond this time, okay? So the first thing I'd like to talk about is nutrition. So kind of jumping into it, what is the importance of nutrition in your critically ill or injured patients?
Great question, Dennis, and it's a question that everybody needs to deal with. It doesn't matter if you're in some austere environment or in a level 1 trauma center or in some type of support hospital. And nutrition, really one of the big things is energy and healing. And so I think the importance of that cannot be overstated. So I'm really glad you brought this topic to light. It's something that we all deal with.
So, normally, any of our interventions that we do, there's nothing that's free, right? Everything has good and bad sides to it. What are the good and bad going along with starting to feed an injured patient, a critically injured patient?
Right. What are the pros and cons to feeding an injured patient? It really depends on where these injuries are. So, in other words, injuries to the gut, meaning the alimentary canal, meaning the stomach, the small bowel, the intestines, if you will, and those are patients that have their own challenges when feeding, and I'll get back to that in a second. But then there's the other patients with that don't affect the intake and output of nutrition and waste. Such as injuries to the extremities, burns, for instance, and head injuries, which have their own unique requirements when it comes to nutrition. So let's start off simple, and we'll say, how will nutrition affect and the pros and cons of feeding somebody of an extremity injury? Well, I don't think you're really going to find very many cons in feeding somebody with an extremity injury, other than if, say, they're a diabetic. And then you have to weigh the carbohydrates which you deliver. But other than that, take away that, all things being equal, you want to get any critically injured patient nutrition as soon as possible. And that's all based on metabolic demand. And by metabolic demand, I largely mean energy expenditure. Not in terms of running a race, but in terms of cellular metabolism. So I don't want to get caught in the weeds. That won't help your listeners at all. But basically delivering protein and fats to your patient so that they can convert these proteins and fats to long-term energy. And what that means to that patient is healing. In other words, how quickly can they heal that stump? How quickly can they overcome a potential infection? And things like avoiding decubitus ulcers, for instance, and pneumonias. And all that has to do with delivering nutrition in a timely fashion. Critically ill patients who have injuries, say from burns, burns probably have the highest metabolic demand of all patients. These patients are compromised for any number of reasons, which your listeners know, such as temperature regulation and infection. And again, delivering these patients nutrition early is very, very important. Their metabolic demands are multiple times higher than not only a healthy patient, but also even, highly tuned athletes and so forth. But say they're just, indigent people, you still need to deliver high calorie nutrition, again, in the forms of fats and proteins to these patients early and often. And then the head injury is very similar. The head injured and the burns patient, these patients, again, the highest metabolic demands of all your patients, of all your injuries, and these patients need to be fed as well. And when I talk about feeding in these patients, in general, unless I say otherwise, it means orally or enterally, if you will. Now, there are times when you may not be able to feed them in the mouth. They may be unconscious, and you still need to get nutrition in. And that you can do in the form of tubes, right?
Mm-hmm.
Either nasoenteric, nasogastric tubes that go either through the nose or through the mouth into the esophagus and down into the stomach. And in general, that's how you would feed these patients who are unable to be conscious enough to eat on their own. There are pluses and minuses with these tubes, and maybe that addresses part of your question: who and when can you feed? These patients really need to have their head elevated. We talk about having their head elevated about 30 degrees. If you can't feed them with their head elevated, they have a very high risk of aspiration. These tubes keep the esophagus open, and they will reflux. All patients reflux and aspirate to some degree. And for the amount of volume you need to instill in these patients, again, mostly in the terms of proteins and fats. And remember, these are the ones that your stomach keeps around longer. It won't empty as quickly with proteins and fats in them. These are the ones that have a higher potential for aspiration. Now, in a hospital, for instance, we can get that tube into the jejunum, which is that second part of the small intestine, the first part being the duodenum. And these patients who are being fed directly into the jejunum have an exceedingly low risk of aspiration. Probably not something that you can do with prolonged field care. You have to be, or you should be, at a hospital. Once in a while, you can get lucky and a tube will make its way into the jejunum through peristalsis. But I don't know that a lot of folks carry a tube long enough to reach that area. So again, in general, for our conversation, we're talking about a tube that just goes into the stomach, and that's what we would call enteral feeding if they can't eat on their own. And I think those are so we talked about head injuries, burns, and extremities. And then there's pluses and minuses in patients who can be fed directly into the gut. Now, again, very, very few minuses feeding patients into the gut and injuries to the abdomen. However, there are patients that you may have who have things that are called fistula. And a fistula, for our purposes here, are where the intestine, whether it be the small bowel or the colon, are emptying onto the surface of the skin. And this generally happens with penetrating injuries, and the healing takes place where there is a leak from the intestine, which wears its way into the atmosphere. And that's what we would call an entero or colon atmospheric fistula. So an enteroatmospheric fistula, a coloatmospheric fistula, same thing as an enterocutaneous fistula or a colocutaneous fistula. So I'll go over that slowly again. You have a penetrating wound to the abdomen. We can say a stab wound, or you can say a gunshot wound. The patient does not succumb to the wound itself, and over time, meaning a matter of days, the bowel, whether it's small or large, leaks onto the surface of the skin. If you were to feed these patients in an austere environment, so you cannot evacuate this patient in 3 to 5 days, but now you're sitting on them. Maybe they're coalition forces or something along that nature, and you can't operate on them. It's impossible to evacuate them for whatever the reason. And all of a sudden you see either foul smelling or foul looking material leak through the skin. These are fistula. And if you feed them, you get more output. Why is that bad? That's bad because A, it's horrific for the skin. It breaks down the skin and it makes a small wound a big wound. And two, you're losing a lot of fluid. And if it's small bowel fluid, you're losing a lot of nutrients, meaning you're losing vitamins, minerals, salts, and digestive enzymes and digestive detergents, if you will. In other words, bile, which breaks down fats and so forth. So it's really deleterious to get a fistula. Even in the best of situations, the morbidity and mortality can be almost unreasonably high. And if that occurs in a austere environment, you could, these patients will not do well.
Right. Well, that's definitely a lot more complicated than I thought. I was just thinking of aspiration risk.
Yeah. So, at many academic centers, these patients spend a long time potentially in the ICU and also on the floor, and you come up with various means of dealing with these fistula. And one way is to feed them through their veins or their IVs, if you will. We call that parenteral nutrition or total parenteral nutrition. Or they go back to surgery and you try and repair it. And you certainly can do that, and it's certainly been successful. But just like life, when you do choose to take these patients back to the operating room to repair a fistula, timing is everything. So, and that has to deal with anticipating inflammation, anticipating its ending, and then a very, very patient surgeon who is willing to care for that patient, because that patient and you have just formed sometimes an albatross-like bond for weeks, potentially months.
So other than fistulas, potential for aspiration, you mentioned sitting up the head of the bed. Obviously, you're talking about just the shoulders, not their actual head. But does that, by sitting them up, does that alleviate the risk or for aspiration?
Yeah. So does it alleviate it? It doesn't mitigate it. It doesn't make it zero. It decreases the risk.
Okay.
Right. So you and I aspirate all night long, right? Mm-hmm. But that's micro aspiration, and that tends not to affect us in the least. We're talking about aspiration such as more than water brash, and more like vomitus, meaning the lower esophageal sphincter is a physiologic sphincter. It's not a true sphincter. And so it opens and closes throughout, the day and evening and so forth. And it won't prevent boluses of fluid from going up the esophagus and then into your oral pharynx and then being aspirated in a bolus, versus the microaspiration you and I do when it's just, a little bit of spit here and there. And being intubated or trached does not prevent that. I still hear it even today in 2020 and so forth, where people say, well, they were trached, I want to trach them or I want to intubate them so they don't aspirate. Well, that doesn't fly.
Right. They
still will aspirate despite an inflated balloon.
Okay.
And so the pressures at which you would occlude the esophagus or the trachea are unreasonable to use that as a mechanism to prevent aspiration. So yes, getting back to what you were saying, raising the head of the bed, the common goal is 30 degrees. So greater than 29 degrees and less than 60 degrees is generally the accepted elevation of the, I said head, you said shoulders, and I like the way you said that better than I do. I think raising the torso to a 30 degree or greater than 30 degree altitude would be the goal.
Mm-hmm. Obviously, there's lots to do when you have this patient, and feeding them is way down the list, right? Before we even, are honestly considering feeding a patient, kind of what things, I mean, obviously we're talking beyond March, right? But what kind of things do we have to have under control before we could even consider, feeding this patient?
So, what kind of things do you have under control?
So I'm thinking,
assuming you've made it through March. Yeah.
I'm thinking resuscitation is done, things like that.
So, you bring up a good consideration. So resuscitation, the patient really should be resuscitated. I suppose in some way you could say nutrition is part of the resuscitation. But remember, if the cells are starving, if they're literally starving to death, and when I mean cells are starving, I'm talking more elemental. I'm talking about oxygen. I'm talking about flow. And nutrition won't do any good, and it will do potential harm if you try and put proteins and fats in somebody's gut meaning basically the stomach and small bowel. If you try and put these types of heavy molecules, if you will, heavy type of nutrition in there, the body won't use it. So you have to establish flow. You have to resuscitate the patient, and once that is done, then you can start feeding them. So the regular things like airway and hemorrhage and stuff that has to be taken care of. And in general, we want to start nutrition within 24 to 36 hours of a critical injury or a critical illness.
Okay. Now, in a previous podcast, podcasts like 5 or 6, right? Very early ones. They were mentioning that there's no need to feed our patients, at least the trauma patients that they were talking about at that time, for at least like a week, that there won't be any harm for waiting that long. But this is really why I wanted to start talking about it, because in the hospital systems, they're talking about, like you said, within 24 hours feeding this patient. So I guess what's the harm that will come from waiting beyond that time? Waiting beyond the 24 hours, 36 hours, and waiting those couple of days.
Right. I don't know who said that. Every podcast that I've listened to of yours has a more than qualified, a super qualified person, leading that podcast with you. Mm-hmm. So, I will tell you that again, in 2020, you're hearing both. You're hearing that we don't need to feed this patient right away. In other words, even recently I had a patient, I was caring for somebody else's patient who had a perforated gastric or gastroduodenal ulcer. And in my practice, if I do that and I'm operating on them, I put a feeding tube in them and I start feeding them right away, meaning maybe not that day because I just want to make sure they're resuscitated. But I will feed them within 12 to 24 hours because I have direct access to their gut, because I put a feeding tube in at the time of surgery, not a surgical feeding tube, but a nasoenteric feeding tube. And the reason why I do that is because patients need to heal. we need to deliver enough energy for them to heal, both from a metabolic standpoint and, quite honestly, a clinical standpoint. So sometimes, we're gilding the lily. Sometimes we're threading the needle by doing these things because they're the right thing to do, along with 10 other things. What I'm talking about is there is a clinical benefit, meaning a measurable benefit for these patients if you feed them early. And yes, you will find some people, both newly trained and trained years ago, who feel that you don't need to feed these patients for 5 to 7 days. And you know what? If they come in healthy, if they're a 23-year-old or even a 30-year-old and potentially a 40-year-old, can you starve their body, for 5 to 7 days? And the answer is, yeah, of course you can. And if they come in healthy, they've been eating, their nutrition was optimized prior to whatever event that brought them in, will they do okay? And the answer is yes. A majority will do okay. And there's a minority who will not do okay. They'll have prolonged hospital stays. They'll have complications. Maybe they'll have 1, maybe they'll have 2, maybe they'll have 3, and they will pay for it. So like everything else we do, probably in life, I was going to say in medicine, but probably in life, there's, like you said, there's risks and benefits. And I tell my patients exactly what you brought up, is that everything we do and everything we don't do carries risk. And it just depends on what side of that risk you want to be on. So for $20, I put a feeding tube in, and for another $20 for, maybe a day, I give them nutrition, and I rarely, if ever, see any risk. I shouldn't say that. I rarely, if ever, have seen any deleterious or adverse event come from feeding my perforated ulcers early. Or I shouldn't even say early, timely, within 12 to 24 hours. Mm-hmm. So what do you do about your soldier that gets injured downrange, or coalition forces, or families, or indigent people there who are injured that you're caring for? And the answer is, if you have the means, I would go ahead and feed them.
Yep.
All things being equal, all these risks we talked about, and the knowledge and the ability to feed them. If you have a choice between feeding and not feeding, you feed them within 24 to 36 hours. And if you don't, it's a risk, and you may get away with it. But if they are not nutritionally replete, if they're not resuscitated, and you wait that 5 to 7 days, somebody's going to pay the piper, whether it's the patient, or the patient and the surgeon, or the patient and the medic, or the patient and the nurse. They're going to bring you with them. They're going to bring you down with them, because nutrition is the currency of healing.
Yeah, no, very good. And obviously we're talking about the medical benefits of this. There's also a logistical side. There are many other aspects of it. And whether, one medic decides to do it or not to do it, he's going to have to make that decision, taking all the factors into play, to actually come up with what's the right thing to do. So it might be another plug for telemedicine. If you're thinking about doing it, it's probably worth the call. I think if you're getting down to should I feed him or not, things probably are fairly calm, where you have time to go ahead and call somebody to make sure you've got all your ducks in a row before you start pushing fluid or some kind of feeding formula.
And you've heard me speak a lot about proteins and fats because they are so important for nutrition. But at its basic element, carbohydrates, and we're not necessarily talking about refined sugar and stuff like that, but whether it's fructose or glucose, that's still energy. It's kind of empty energy, but it's still energy. And if you're in a jam, it's not a bad thing, and some people would argue potentially it's a good thing. It'll keep for a time. It will keep your body from breaking down its own fats and proteins, and selectively using the glucose that you're feeding the body through the veins, for instance, like your D5s and D10s. It would selectively use that energy first. Now, it won't be providing the necessary elements, amino acids, and so forth for protein building. But remember, in the early phases of healing, you're catabolic. And I think that's an important understanding for medics, non-medics, anybody who's caring for a critically ill patient at home or away, is you are catabolic. And there's really very little you can do to make these patients anabolic. And what I mean by catabolic is you're constantly breaking down, the body is constantly breaking down its fats and proteins, and using all of those for energy in the initial phases of critical illness. And it's not till farther on down the road where the body becomes anabolic. We all think of anabolism or anabolic like steroids, like football players and athletes, performance-enhancing drugs, stuff like that. But anabolic just means that the body's putting itself back together. And so what can we do in those early phases? And, we've looked at supplying patients with testosterone and its synthetic analogs, oxandrolone and so forth, human growth hormone. And really these have provided some benefit in pediatric patients and adult patients. We haven't seen the outcomes in converting our catabolic critically ill patients into an anabolic patient. Mm-hmm. And so you get this muscle wasting. And along with that, you get the decubitus ulcers and things like that, which are really a problem, both from a wound aspect as well as a protective barrier for infection. Remember Christopher Reeve, he died from an infected decubitus ulcer. And so getting these patients anabolic is very difficult. And really the only anabolic hormone, if you will, during the early phases that we all have and have access to is insulin. But insulin has its own issues when delivering that exogenously as well.
So this catabolic state, is that from the stress response, or is it just a combination of the inflammatory response and kind of all these things? I guess I'm trying to think, when we in medicine, try and force the body to change from what it's doing, it's either very difficult or impossible, or it ends up with a really bad outcome. I'm wondering if it's not the body doesn't do that on purpose to make it catabolic, so that it reprioritizes the thing, I guess, functions within the body.
Yeah, no, I like the way you think about it, and I like the way you're asking me to clarify that, because it is not, the body does do it on purpose. The body absolutely does it on purpose. Analogous to like cancer, right? Cancer is just healing over and over and over again in an uncontrollable fashion. And the body does that on purpose, even though it doesn't really make sense, because eventually that cancer kills the body. So it's not beneficial. So let's move away from cancer entirely and understand that the inflammatory state and the catabolic process, they go hand in hand. In the end, it doesn't, the body is trying to harness all the energy that's available, whether it's exogenous energy, meaning getting fed, exogenous meaning outside the body. So getting fed through feeding tubes or orally or parenterally through the vein, anything that's available. And so if it can't get enough energy from that standpoint, exogenously, then it's going to turn on itself and it's going to rob the body for energy, glucose, glycogen stores from muscle and fat and the organs, the liver. It's going to do whatever it can so that it can restore itself to its original milieu meaning, mixture of things, where the body was in a more or less a homeostatic state. Mm-hmm. So all of that is fancy garbage words for saying the body's just trying to get to where it started from. Right. And in order to do that, it's gonna use whatever's available, whether it's food or the substrate of the body itself, meaning muscle and fat.
Mm-hmm. All right, Mark, you sold me. On this patient, I'd like to feed him. Okay.
Okay.
I think I'm hearing bowel sounds. The patient's passing gas. So I'm thinking that he can accept it. I guess so. How do I go about setting this up? I don't have the ability to,
Could we take a step before that?
Sure.
I hate to interrupt you, Dennis.
That's all right.
But I do want to hit on a couple things that you just brought up just now. And you said that the patient has bowel sounds and they're passing flatus. Mm-hmm. So from a more or less an academic standpoint. So for number one, bowel sounds, they come from the stomach and they come from the colon.
Okay.
So what you're, I think, referring to is they don't have an ileus. An ileus, in its most layman terms, is when the gut goes to sleep, right?
Right.
And so, which is a little different than a gastric ileus or gastroparesis, meaning that the stomach itself has fallen asleep. And all this means is that there's no peristalsis in the gut, right? Mm-hmm. And peristalsis is the natural locomotion of aboral feeding. In other words, from the mouth to the anus, if you will. Okay. So when we take a bolus of food, say a hamburger, we chew it, right? And we macerate it and it goes down the esophagus into the stomach. The stomach turns solid into liquid. That's what it does. And it keeps things around until it gets it liquid. And then it sends it down to the duodenum, which has enormous absorptive capacity. And from the duodenum, it goes down the small bowel through multiple feet of small bowel, and certain nutrients are pulled into the intestine, into the lining of the intestine, and then eventually into the bloodstream and onto the liver. And then anything else becomes waste, right? Mm-hmm. And so that waste now enters in liquefied form into the colon. And in the right side of the colon, that liquid waste starts to become solid. So your colon's responsibility is basically to be a big bag to hold solid waste and to absorb water. I think that's what your audience needs to understand, and I'm sure most of them understand this, and I'm merely repeating what they know. So I would ask you, if you have a patient who is distended and passing gas, would you feed them? And many of us probably would not. Okay. Mm-hmm. And if they're distended and they have bowel sounds, would you feed them? And again, many of us probably would not. Well, what would you do if they were not distended and they don't have bowel sounds? Well, a lot of us probably would feed them. Okay. Not everybody. Some people are married to bowel sounds and married to flatus. So what I pose to you and our audience is there has to be some clinical intuition here. And if we know that bowel sounds come from the stomach and they come from the colon, that doesn't mean that the small bowel, which is critical in absorbing all these nutrients, is awake and working. We just don't know that,
Okay.
right? And we teach dogmatically, and it's probably true, but I can't tell you it's true all the time, that the alimentary tract, if you will, comes back in a more or less a predictable manner, and the stomach tends to be last, the small bowel tends to be first, and somewhere in there the colon wakes up, and that works. So now that we have all this information, how do we know when to feed our patients? And so I think that's where this process of, well, if they have bowel sounds and they're passing flatus, we can feed them. And that's not always true.
Okay.
So again, that goes into your risk-benefit cost analysis equation of should we feed our patients.
Okay.
And the more sedentary our patients are, the more they're lying down and not doing anything, the more likely they are to develop this ileus, this gastroparesis. And certainly if we're feeding them aborally through the mouth and expecting it to go downstream, and we would expect that their stomach would be the very last and may even go to sleep for a long time, and that would be quite problematic. So again, it's a cost benefit thing that your medic and those caring for that patient, along with the medic, will have to make a determination whether they can feed them or not.
Okay.
And flatus, the best way, the one point that I do want to make, and I think we're learning more and more, is that the best way to keep the gut working is to feed it. And so to avoid an ileus, I will feed a patient. In other words, that's one of the reasons why I feed my patients early. If you stimulate the gut, if you really want to stimulate the gut, feed them as high as you can, meaning hopefully orally.
Mm-hmm.
But if you can't feed them orally, feed them in the stomach, and that will keep the gut awake. Does it work 100%? No. There's never always, and there's never.
Right.
And so stimulate that gut and feed them. And the body's largest immunomodulatory organ, meaning our body's most important, strongest, largest organ that helps prevent infection is the gut, is the small bowel. And so that's why it's important to keep the bowel happy. And you keep it happy by feeding them.
So if you're not using bowel sounds and or flatulence, or actually having some kind of fecal matter come out, what other exams are you doing to kind of assess that small bowel? Is it just your abdominal exam, or?
Great question, Dennis. And really, if that's the message that I've conveyed, it's slightly erroneous. In other words, it's part of the equation.
Okay.
These are all data points.
Right.
And so what I want to convey is you can't solely rely on one data point. You can't rely on bowel sounds and flatus. You can't rely on flatus. You can't rely on bowel sound. You have to look and see, is the patient distended or not?
Okay. Yeah.
Is the patient able to eat or not? Are they hungry, or do they have an appetite?
Mm-hmm.
Right? So hungry means, basically, are they starving or not? Appetite just means, does a sensation of food have a response? Is there something that they want in particular? Do they want a payday, a Babe Ruth, a vegetable, a fruit, or a steak, and so these are things that you can use to evaluate whether they're ready to eat or not.
Okay.
Not everybody, and you can't just use those either. I've had plenty of trauma patients that you say, whatever you do, do not eat. we'll feed you tomorrow, we'll feed you in a couple of days, and yet they find some way of conning some nurse or tech or friend from home to bring them food, and it's not a good outcome.
Right.
So it's all those things together, and that's why your medics are medics. That's why our nurses are helpful, and everybody gets a say and has an opinion. Ultimately, somebody's going to have to make a decision, but sometimes the patient isn't cooperative or just tries to override those decisions.
Right. Okay. So, I mean, just looking at myself, other than patients who have said, I am hungry, and I know that they've been resuscitated and their mental status is great and things like that. Like, okay, here, I'll get you a snack. Other than people like that, I've never had to feed anybody who's been unconscious and in a critically injured, right?
Right.
So let's say, we get to warm and fuzzy, like we have this critical patient. He's been severely injured, but we're leaning on the side of we'd like to feed him. Okay, we think it's safe to at least attempt it. We have an NG tube because the patient cannot talk or indicate he's not aware enough. What do you feed him? I mean, I don't have pre-made solution, right?
Right. So you do your best to get something that will pass through that tube that won't clog the tube. That's my best answer. So my guess is not everybody's carrying a blender. Not everybody's carrying around a coffee bean crusher. But you try and find some type of sustenance that can be passed in liquid form down that tube. And you may have to, go through trial and error. In other words, things like we talk about the brat diet, right? A very elemental diet. And quite honestly, that this is getting into another topic, which in general, it's called hypocaloric feeding. Or trophic feeding. People love to toss around the word trophic feeding. And for the longest time, years and years and years, we used trophic feeding. That was something to make us clinicians, surgeons, medicine doctors, intensivists, whatever you want to call us, we used to use that term, make us feel good. Well, finally, they came up with kind of a definition for trophic feeding, and that was somewhere between 50% and 2/3 of our caloric needs, right? And so we would say, just feed them trophic feeds. And so, you compare, some, 300, 280 pound lean door crusher, and you compare, some administrator, those two body habituses, and what's trophic for them? Well, I don't know. And does it really matter in that initial phase of nutrition? And so my answer to you, Dennis, for your question is, I start off really low, really slow, and I give them hypocaloric feeds. Hypocaloric feeds meaning just a bare minimum, just to where the fluid is colored. So whether it's, bananas that have been, pounded down into liquid with a little bit of D5 or just maybe plain water. And if it's down a tube, maybe normal saline is fine. Just not a lot, just something to liquefy it, make it thin enough to pass through that tube. And for 24 hours, it's going down that tube somewhere between, you pick a number between 10 and 20 milliliters an hour.
Okay.
And again, that's probably just enough to stimulate the gut. So if we look at hypocaloric feeds or trophic feeds, if you will, is there any benefit to that? And the answer is, yes, we think so. The nutrition literature is full of point counterpoint. For every paper you find pro, you'll find at least one or two con. And we go in circles a lot, And I think we fall on the best practice, most logical guidelines for that. And I know I introduced you to the Aspen guidelines. And in Europe, they're the ESPN guidelines, the American Society of Parenteral and Enteral Nutrition, or in Europe, the European Society of Parenteral and Enteral Nutrition. And this will give you, the best evidence to date, and the guidelines are like any other guidelines. The majority chest pounders and table pounders write these guidelines and have, recommendations based on, level of evidence and grade of recommendation to proceed with, whatever it is you're looking for. So your patient that you presented would get, some type of bananas, and who knows, maybe rice and, toast and whatever you can macerate or liquefy and get down that tube at a very low rate for the initial, 24 hours or so. Maybe it's 48, just to make sure that the gut's working. And if they do aspirate, you're there for them. It's time. You know what to expect. You're doing the basics, like you said. The torso's elevated. You're doing the best you can.
Mm-hmm.
If they're unconscious, they won't be able to tell you that they're nauseated. But if their abdomen gets distended, to stop. And you wait, and eventually, things will happen. They may pass gas. They may have a stool. Things like that.
Okay.
So it's not critical that you get them to their goal nutrition right away. Feeding them, that 50% to 2/3 in, the next several days is perfectly adequate. And it may be trial and error. Some days are good, some days are not. Getting them to be up and moving, if at all possible, is enormous. That's really good. And if you can't, at least you're providing the basic elements, and you're actually barely providing any elements in that first 24 to 48 hours, 24 to 36, what have you, when you're giving them that very little 10 to 20 milliliters an hour of some type of nutrition.
Okay. So you don't just go straight for the protein powder down the tube?
No, protein powder is another way of giving, really good nutrition. What's going to happen is if your patient, for instance, has not been fed, say in that 5 to 7 days, remember the small bowel under a microscope looks like a shag carpet, a healthy small bowel. Now, if you looked at that small bowel under the microscope, in that kind of 7 to 14 day mark, that shag carpet has gone to indoor-outdoor carpet to basically a smooth floor, if you will.
Mm-hmm.
And so, without the absorptive capacity of that shag carpet, the proteins and fats will not only will they not be absorbed, but your patient will have the squitters.
Okay.
They will put out volumes of stool. And with that, they lose all kinds of electrolytes. They lose potassium, and probably, arguably, more importantly, they lose the ability to retain fluid, and they become dehydrated, and that's obviously very bad. So, if you feed your patient proteins and fats right away after a prolonged fasting period, you're really going to run into problems with electrolytes and fluids.
Yeah.
Yeah. The other thing,
now,
Dennis,
I was going to say, we're starting off at 10 to 20 milliliters an hour. Do you increase from there? Say, 12, 24 hours later, like things are going just fine. Do I go up? Or do I just keep it to maintain? Do I maintain that and then change the contents of that feed? Or do I increase the volume of that feed? How do I adjust fire, and how do I assess that I'm moving in the right direction?
Well, here's the good news, Dennis. The good news is it's all style points from here on out. So you go to one hospital and their protocol, if you will, is to go up by 10 milliliters every 4 hours until you reach goal. And you go to another hospital and it's go up by 20 milliliters an hour until you reach goal. And you go to another hospital and they say go to 3/4 strength and then full strength, and they have some variation. What that tells us is we don't know.
Okay.
So again, it's trial and error. It's style over substance, and depending on your patient's needs. So a burn patient, tends to need a lot of fluid. I would be pushing more towards increasing fluid than I would say a patient who has a bad crush injury and got a massive resuscitation and needs to autodiurese. And again, autodiuresis comes when the proteins in the blood and the vessels have sealed and the oncotic pressure rises and, they start urinating. You don't want to give somebody who's already gone through a big resuscitation and who's now starting to give back fluid. You don't want to give them more fluid.
Mm-hmm.
Right?
Right.
So then those are the patients I tend to increase the concentration of the enteral feeds and see what we can do about keeping fluid, minimal fluid going in.
Okay. So starting off on the brat diet, and you do that for a day or two, do you then start incorporating some kind of protein with that, or?
Yes. Yeah. And I think you hit the nail on the head. I think one of the great ways of doing that downrange is to get them protein powder and mix that in there so they do have the proteins and fats. So the other thing that I wanted to add was we never discussed like parameters, like how much protein is good protein, and in general in these patients who are stressed. Should get somewhere in the vicinity upwards of 1.5 to 2 kilocalories per kilo per day. So that's how you can judge how much. We talked about goal tube feeds. We talked about it in the framework of milliliters an hour. But again, the importance is how many calories per kilo per hour is needed. So I wanted to give you that framework for protein, and then calories. This would be in the order of 5 to 6 grams per kilo per day, in the form of lipids and carbohydrates. Is where they should get their calories, and then non-protein calories. Again, a framework would be anywhere from 25 to 30 kilocalories per kilo per day. Calories. You want to just use calories. So anyway, I just wanted to bring that around to those numbers because of the medics who are taking care of these patients need that kind of guideline to calculate how much protein powder, if you will, to put in their fluids in their NG tubes or OG tubes, however they're delivering it to their patients, just orally. Would need.
Now, how do you assess? So I can obviously, I'm giving him 20 mLs an hour, and I've been doing it for a day, and he hasn't thrown up yet. What am I doing for an assessment other than, he hasn't puked, so I must be doing good. Am I just continuing that assessment for bowel sounds and looking for a distended abdomen? How do I know I'm moving in the right direction? Yeah.
So it's not going to be measured over minutes or hours. It's going to be measured over days and weeks, and that's the hard thing for us to understand sometimes. And it's also measured by the things that are not happening. In other words, they're not getting pneumonia. They're not getting decubitus ulcers or soft tissue injuries. They're they are, they're getting enough energy to do things like swing their legs over the cot or stay awake for longer periods of time. That's how you're going to measure. All of these things come in very, very prolonged clinical victories, like the things I just mentioned. So you may not know the early things like bowel sounds and flatus and stool and so forth. Those are somewhat measurable in the order of hours, but I wouldn't expect, I wouldn't change anything, make any drastic changes without a series of victories or losses, during that period.
Okay. So generally you're more holding fast with your plan until, you start seeing some kind of distension or
Yep.
something like that, right?
Yeah. If they vomit, stop. If they don't vomit and they're getting distended, I would stop. Okay. And if they don't vomit and they're not getting distended, but they're not having bowel movements or flatus, I would keep going.
Okay. Yeah, very good. I don't know. Is there
Dennis,
anything else?
There is one. Yeah.
Okay.
There is. And the only reason why, there's a couple of reasons why I want to bring it up. One is the visual and pulling from memory. But many of your readers have seen the movie Band of Brothers. Mm-hmm. And I think you and I have spoken about this when we've done our prolonged field care exercises, to the teams that get their training at Ragged Edge. We talk about nutrition, and we refer to that scene in Band of Brothers where the American troops walk into a concentration camp, and they're ordered to give them water and bread and so forth. Mm-hmm. And then the battalion surgeon comes by and says, "Oh, stop feeding them," and it makes no sense to anybody. Right? And they're like, "What do you mean? They're starving to death. These patients are cachectic. They're feeble. They're in, stages of dying. And the one thing that they need is nutrition." And many people in the audience do not understand withholding the nutrition. And basically what that gets to is that, yes, these patients are starving, but if you feed these patients food high in calories, in particular carbohydrates like bread, mm-hmm. What happens is it changes the way the cells take in nutrition and depletes the cells of phosphorus. And that phosphorus will, when depleted, in a very complex biochemical reaction, take away energy, and they can go into severe respiratory failure, and we call that refeeding syndrome. Refeeding syndrome is actually a fairly dramatic. It can be fairly dramatic, where when these patients are introduced to carbohydrates in particular after prolonged starvation period, they go into respiratory failure and ultimately into multi-system organ failure if not identified early enough. So the battalion surgeon gave the correct order: do not feed those patients. They will need to be resuscitated, but they will have to have their electrolytes followed very closely. Mm-hmm. Now, we see this in the hospital from time to time in patients who have had prolonged periods of starvation. Either it's iatrogenically introduced, meaning the doctors have said don't feed them and they really did need nutrition, or maybe it's self-induced, right, with psychiatric patients, or a combination of just, really bad things happening and the patient has not had their nutrition. Cancer is another one. Mm-hmm. And we try and feed them because we know that early nutrition is important. And we put them in a refeeding syndrome. They go to the ICU, they get intubated, and now we got to start from zero. And a lot of that can be, it can be predicted. but it should always be anticipated, or at least, well, I guess anticipated is the right word. If they have the history of not eating, then you have to be aware of this refeeding syndrome. And then the other thing I really want to touch on, Dennis, many of your audience members, they understand the Krebs cycle and the function of the mitochondrion to generate energy in the form of ATP. And that ATP is the story of how sugar or glycolysis is used to generate energy in the form of phosphates. And that's how you can complete the story of refeeding syndrome, where phosphate or phosphorus rather is depleted, and therefore your energy stores go low, and the ability to breathe is impaired by refeeding. So I think the important message is on the macro level, not on the micro level. But again, it just enhances a greater understanding and provides the information that glucose should definitely be used, despite the emphasis for proteins and fats to provide that energy, because eventually they're broken down in their most elemental level to provide the substrate for glycolysis.
What kind of timelines are you talking about for the refeeding syndrome? I mean, it's not like a day or two.
Days. No. We're talking really prolonged fasting. We're talking kind of past the 7-day mark, where you're getting close to the 14. Okay. You know, your body's really, really starving. So you can be fat and malnourished, right? I don't think you're allowed to say fat anymore in this world. You
That's
definitely
okay.
can't.
Nobody listens anyway, so.
You can meet the insurance requirements for a high BMI and be obese and still starve.
Yeah. You
laugh, but you would be surprised at the things you get called out for.
Right. Yeah.
We're very sensitive.
Yeah.
Yeah. So anyway, so my point is yes, your body can be starving, and yet you can weigh more than the insurance companies allow you.
Yeah.
And you could go into refeeding syndrome. But in general, those patients will start drawing from their, fat stores and muscle stores. The big shock are these cachectic patients. And that's when we get the refeeding that is so clinically significant that they end up in the ICU, and you get, you have to give them boluses of potassium and phosphorus to keep the machine of the body going. Mm-hmm. Yeah. The last point I want to make, because this is such an important topic, is one that is discussed in clinical rounds in a resource-rich environment. Meaning, we're not talking downrange in some hut in some unknown village. We're talking about a hospital that has capabilities of measuring important contents of the blood, and that is the concept of these acute phase proteins to see if a patient is nutritionally replete or not. Replete meaning replenished, and that is the acute phase proteins of albumin, prealbumin, transferrin, retinol binding protein, and so forth. These are proteins in the blood that people often refer to see if their levels are high enough such that they are nutritionally starving. So if you think about a patient that needs to be in a hospital, there's probably a reason, right? And that reason can be anything from injury to infectious reasons of various sorts, trauma, the need for surgery, things like that. What happens when there's inflammation is these acute phase proteins, retinol binding protein, transferrin, albumin, and prealbumin. People love to talk about albumin and prealbumin as being markers of nutrition. Unfortunately, this cannot be a more erroneous goose chase. So when you have inflammation, when you have trauma, when you have illness, when you have infectious disease, when you have fistula, when you have ad nauseum, you pick, it drives these acute phase proteins down very quickly. Mm-hmm. And so even when their levels are low, that doesn't mean that they're nutritionally replete. That just means that there's enough inflammation that those numbers are down. So what many people will refer to is, well, we need to feed them because their mortality is high if their nutrition is low. And the answer is, you're absolutely correct. We do need to feed them.
Right.
The metabolic demand is super high, but because those numbers are low, has very, very little, if anything, to do with nutrition. Yes, in a patient who's at home, who's cachectic, yes, those numbers will be low. Yes, absolutely. But just because there's inflammation, those numbers will be low as well. And yet they have a history of being totally normal, totally healthy before they got in that car crash. So if you start getting those numbers and they're low, does that mean that they weren't eating or they're nutritionally starving? The answer is absolutely not.
Right.
What that goes to say is we should feed our patients in a timely fashion. In general, those patients should be fed, all things being equal, within 24 to 36 hours. There are those patients who will fall out of that, and those are patients who have a disrupted gut. For some reason, you don't have to feed those patients right away because you may be adding to their morbidity, but those are the one-offs.
Right. Right. Now, I guess when you're, kind of quantify disruption, somebody has, small holes through the abdomen, will they feed those patients or not? No.
Nope. They need some type of definitive treatment before you feed them, because all you're doing is promoting more fluid spillage into the abdomen or into the atmosphere.
Okay. All right. So essentially the cutoff is as long as they have an intact GI system, they've been resuscitated, and you've put some kind of, safety measures in place as far as reducing the risk for aspiration. There's no real great reason to not try to start feeding within, in 24 hours.
Correct.
Is that okay? Yeah, absolutely awesome. Is there anything else you can think of?
I think we hit on most of the main topics, Dennis. As you can gather, the discussion surrounding nutrition is absolutely enormous. Mm-hmm. That's probably mostly because we don't know all the answers yet, but it has far-reaching implications. The specifics around the head injury or the burn patient or the cancer patient, or the patient who's just lacking the ability to get fed directly. You could go on ad nauseum about all these issues, including just plain fluids alone.
Right.
So I hopefully we at least we didn't confuse anybody, and hopefully we pointed folks into a stronger direction, built their intuition up and their confidence in approaching nutrition in the patients that they'll encounter.
I mean, everybody, you have at least some kind of a human connection, some kind of emotion, and that when you're feeling hungry, you're wondering, I wonder if this patient is also hungry. I feel like I need to do something about it, but I don't know, So I think at least by giving some kind of education in the good and the bad about it, what kind of assessments to find out if this is the right patient for that type of intervention, and how to do it and how to assess if you're doing the right thing or not. I think I really doubt you're going to hurt somebody that much if you start off at 10 or 20 mLs in an hour. If they start to descend, then you stop. I mean, really at that point, and you already have an NG tube in, if you're really concerned that you're going in the wrong direction, just suck it back out.
I think that's a very reasonable approach. I would agree.
Okay. Well, cool. Hey, thank you, Mark.
Thank you, Dennis. It's always a pleasure working with you, and certainly these podcasts have they're just invaluable to your listeners, and I get feedback from it. I'm sure like you do, and it's great to know that there's folks out there like you asking these great questions.
All right. Well, thank you.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.